torch to Axel Wolf, who's going to talk about basically radiology and how to get oriented with radiology. Good morning, Axel.
Thank you very much, Puya, for the invitation to talk today. Thanks, participants. So I'm really glad to be invited here. I think it's a great opportunity to take part at your webinars. And yes, I send you best regards from Graz, from our ENT department where I'm sitting right now. And thanks, Mariana. The aim of my talk now will be to talk about some radiologic imaging techniques in general. Furthermore, I want to go into detail to present our CT checklist to give you a structured plan to go through CT scans and give you, of course, some clinical examples why certain points are important in my point of view. So although we love our endoscopes, everyone knows that we need additional imaging to see all different structures for diagnosis and treatment of our paranasal sinus system, especially in FES procedure. We do not perform standard plain film and polytomography anymore because we have a lot of artifacts, we have a lot of blurring, we have relatively high radiation exposure, so we don't perform them anymore. We use CT scans as our modality of choice, of course. Why? Because, of course, we have a nice relationship of anatomic landmarks and our anatomic structures. Of course, we can see nicely our bony structures, we can see soft tissue, but also air and fluid levels if they are there. The standard dose CT scans are already have become better over the last decades, but also with the low dose CT scans, we really have a relatively low radiation exposure to gain more information in certain anatomic areas. Of course, you should have proper magnification. Today on our computers, normally no problem. And triplanar reconstructions we don't need, I use them routinely, but they can help you to understand anatomy. What about time of scanning? For example, here, this is one and the same patient in the acute state of disease, acute rhinosinusitis, and this is the one and the same patient 6 weeks after. So we have really different information, and in this patient, of course, we have a well pneumatized osteometal complex, and there it's not so clear. So also tell the patient he should not go to the radiologist in the state of the disease when it's just worsened or when he has any infection. Another case, very important, previous surgery. Here a case from our department where we have a bilateral damage of the skull base after a previous external endoscopic sinus surgery. This was the intraoperative situation. You can see here a CSF leak. We applied fluorescein preoperatively, and here you can see nicely using 3D navigation how it looks like if you apply fluorescein preoperatively, and here we see our quite large defect at the skull base, which you can not easily miss in recurrent disease patient. This is just another patient I saw yesterday at our apartment. She came in first time 2008 with Graves disease, and afterwards, a few years afterwards, orbital decompression was performed, and also after this orbital decompression, a mucosal applied. And if you see only this patient, you could all easily think, okay, that's a mucosal, but on another layer, you can nicely see here the orbital decompression, which was performed before the mucosal here and into the frontal sinus appeared. And this is the state today. It's decompressed, but no more chronic inflammatory disease. I told you coronal planes are our roadmap. Axial planes give us further information. Here, for example, the run of the orbital nerve can be nicely seen on our axial CT scans. Furthermore, here an example of a cranial atresia patient. And this brings me to our second point, the septum and the middle turbinate. Just some small clinical examples here. Middle turbinate, septum contubulosa. So nice situation where you can start with your endoscopic procedures. Septospore, another nice beginner surgery. And the third point, after we evaluate our septum and middle turbinate, of course, the uncinate process. Mariana talked about that before. I will not go into detail. We have different attachments of our uncinate process which have to be evaluated pre-operatively, because this will help you to find your way into the frontal and into the during your further procedure. Here, example of a pneumatized uncinate process, or here an example of an uncinate process attached to the orbit, because we like to resect our uncinate process by incision with the sickle knife, which you of course should not do there, because there you are in danger of hurting the orbit using your sickle knife. Evaluate the attachment of the middle turbinate and the uncinate process, the attachment of the uncinate process by finding the drainage pathway also to the frontal recess, or if the uncinate process is attached to the orbit, then of course it forms a terminal recess. Another example, Mariana was talking about that before, an infraorbital or hydrocele. This is something you can also find sometimes in maxillary sinuses. Here, a surgeon lost his tooth implant in the maxillary sinus. And this brings me to our next point, to the ethmoidal bulla. The ethmoidal bulla, as Mariana said before, is one of our most important and constant landmarks. But also here we can nicely evaluate if we do have a suprabullar recess, for example here, or also a retrobullar recess, because this gives us information about our surgical procedure from anterior to posterior. So evaluate if you have any suprabullar recess or retrobullar recess. Here, another example of a herniation of the orbit. This was a patient which had a trauma as a child, and afterwards as an adult, before sinus surgery, we saw that there is a post-traumatic herniation of the orbit into the ethmoidal bulla, and of course, if you run into it from anteriorly without noticing it, you can easily harm the orbit. Posterior ethmoid, of course, or nodal cells, sphenoethmoidal, posterior sphenoethmoidal cells or nodal cells, optic nerve, V2, median nerve. Here we can also nicely evaluate the lateral extension of the lateral recess of the sphenoid sinus. And this is a picture in a posterior in an nodal cell where the optic nerve can run directly without any bony layer through your operating field. So be aware to know if there is any nodal cell in order to be able to differentiate between posterior ethmoid and sphenoid sinus during your surgical procedure. Sphenoid sinus more posteriorly, of course, also be aware if you have an isolated disease in the sphenoid sinus. Here, an example for a meningocele through a persistent Sternberg channel, or for example here, a macroadenoma also filling up the whole sphenoid sinus. Just an example, this was a patient with with the sarcoma of the paranasal sinus system. This is tumor tissue. This is natural, already enlarged natural osteum of the sphenoid sinus. Only just to mention that during surgical procedure, especially in tumor surgery, I like to really evaluate and to find my landmarks like the anterior wall of the sphenoid sinus, which can help you then going from posterior to anteriorly for your tumor resection. Throughout the recess, we talked about the attachment of the uncinate process, and also be aware that this can be asymmetrically, so the way up in one and the same patient can be different during your surgery procedure, and on the left and on the right side. This can be a more complex frontaresis. Here, a patient which was stoned in Iraq war. Here, of course, we performed an open approach because here major parts of the doer were lying free, and we need to drill down to reconstruct our way to the nasal cavity. And in this case, also we used some stents in order to provide the patency as long as possible. Important, the lateral lamella of the cribriform plate. The extension of the cribriform plate, the Keros classification is important because the lower it comes, the skull base comes down. So the longer the lateral lamella of the cribriform plate is, the higher that you are in danger to hurt the skull base on your way up to the frontal sinus. So this is a classical area where the skull base can be damaged coincidentally during a surgical procedure. The anterior ethmoidal artery can be easily found. You look for your for the medial rectus muscle and the superior oblique muscle. Then you see such a notch coming out of the orbit, and this is the position where you can find the anterior ethmoidal artery. It can run free through your operating field, especially if you have a supraorbital recess. But it can also run within the skull base. But in these cases, you are in danger during your procedure to hurt the vessel if you are not aware of it. Here another case, left side here, and on the right side we are quite safe because it's running inside of the skull base. Intrafrontal cells, there are many classifications. I won't go into detail about that, but this is the last thing, so the frontal sinus that we evaluate on our CT checklist. Like here, example of an osteoma of the frontal sinus. So these are the 10 points you should keep in mind. There are different checklists published, which are all fine, but my message should be just have any plan to go for your CT scan that you don't miss any important information. When do we use MRI scans? Of course, the advantage is that we have a good display of soft tissue. We use it mainly in neoplastic processes, in meningoencephalocele, mucoceles, vascular tumors, sometimes inflammatory disease, especially in the follow-up of children, and some rare cases where we use it also in fungal disease. Here's some other examples. For example, a pituitary adenoma in our CT scan, and as we use it for our skull base surgery, we can switch in our navigation system into the MRI scan. So this is a nice example how we can gain our information, especially intracranially. But on the CT scan, we can see our bone structures nicer. Here an example of an aneurysmatic bone cyst in a 14-year-old child. And an example of a juvenile angiofibroma in which we would do also an MRI angiography. DVT or cone beam computer tomography, another radiologic investigation. In principle, it's X-rays in cross-dimensional slices, and they are restructured in three-dimensional layers. They have quite low cost because you don't need a radiologist, at least in Austria. And the good thing is now with the new devices, we can have nice large windows in order to really image the whole paranasal sinus systems. With older devices, we could only use it for the maxillary sinus, and so it was preferred by the dentists, but not by the ENTs. So with the new CT scans, we really do have a nice quality of our pictures, as you can see here. So this is something which we can use also nicely, and I think we will use it more and more in the future. You can also use it with your navigation system. So then I would like to thank you for your for being with me, and I will give over to Mario for the next talk.
What is your recommendation for the correct use of the MRI in recognition of CSF leaks of fungus bowl and cancer? This question is coming, I'm just want to tell you, this is coming from the United States.
Yes, MRI scans in cases of meningo or meningoencephaly seals. So we don't use it in in iatrogenic cases, because then CT scans, if we have the defect at the skull base, it's obvious. But in MRI, MRI only in meningoseals, meningoencephaly seals, etc. Of course, in malignant disease, we use it always before any surgery. For planning the extension, or to see the extension with a better contrast of the tissue, especially if it's going intracranially, etc. And yeah, fungus balls, and just in cases if we have an MRI, which is mainly done by other indications, then you can see it like nicely in T2. But in most of the cases, of course, CT scans are enough. But I think especially in malignant disease and meningoencephaly seals, which may, as I said before, which may be beyond an isolated disease of the sphenoid sinus, they are like to do it pre-operatively in order to be sure.
Okay, perfect.